guideline development. We have a few housekeeping rules that we're going to discuss that Neelam Gia is going to discuss with you today.
Good afternoon, everybody. That was sad. I know it's after lunch. We can do better. Good afternoon. That's better. Okay, so as Diane stated, we have some housekeeping announcements to go over, so please bear with me, but they are important. For those of you in the room, please, please, please make sure your cell phones, Blackberries, any other mobile devices are on silent or even vibrate, and please do not store them next to the microphones on the table. It gives feedback sometimes. The restrooms are at the end of this hallway, as are the water fountains. You will find hard copy packets of handouts at your seats. This is important. Please remember to take those with you this evening and bring them back tomorrow. There'll be additional handouts for your folder tomorrow. For those of you who are joining remotely, please send an email to OSItraining, that's OSItraining@cdc.gov, so that we can take your attendance. Also, if you're joining remotely, please mute your phones while you're on the line, and then we will open them up for questions. You can also ask questions through the live meeting Q&A box I'll be monitoring throughout the training. So for those here in person, again, I hope you initialed your name at the roster and the attendance sheet at the front table. If you didn't, please see me at break to do so in order to get your CDC Learning Portal certificate of completion. At the end of the 2 days, we will update the HHS Learning Portal so that everybody's attendance status is in there and so that you can download the certificate. Also, for those in the room, you'll see that there are mics on the tables, so when you are asking the presenter a question, please do press the button on the mic so that it turns green. Ask your question and then turn it off again. In the event that the building alarms were to sound and flashing strobe lights were going off, please follow me to the nearest exit, but please stick together so we can all be accounted for. Before leaving the room today, please turn in your evaluation sheets, which are in your packets, to myself or a presenter before leaving the room. And lastly, and most importantly, tomorrow, please remember we will not be in this room, but we will be in the DLA, the Distance Learning Auditorium, which is on the first floor of this building. If you have any questions at any point in time, please see me. I am seated in the second row on the right. Thank you very much.
Thank you, Neelam. I'd like to introduce Dr. Joanne Kono. She is the Director of the Office of Science Quality, and she will give you some opening remarks today.
Well, good afternoon, everyone. It's nice to see a front-packed room. This is a really big space, but I hope we'll use it in a more intimate way with folks talking back and forth during the session. It's really fabulous to see old friends and people I get to meet over the next 2 days. So thanks so much for being here. This is the first day of the training, reporting and enhancing quality and implementation of guidelines. And during this part of the training this afternoon, we're going to focus on reporting and clearing CDC guidelines and recommendations. Over the 2 days, you'll have hear a lot of practical information, lots of little tips to help make your guidelines and recommendations a success. How many people in the audience have already been involved in writing or helping to put together guidelines and recommendations? Oh, great. So we have a good group here to keep us honest, to ask lots of good questions, and we're also going to call on you to help inform some of the examples that we use in the presentation. I know there's a lot of variability in people's experience, so we'll try and hit a nice even note and then take lots of questions too. We have about 60 people in the room here. We have approximately 40 participating remotely as well. So we'll try and keep everyone engaged and everyone involved. So regardless of where you're coming from and what your intentions are, I hope you'll have a great experience over these next 2 days. I want to thank a number of people who helped put this together and will help us pull it off. You've already seen a few of them, Neelam Ghia, Dr. Diane Matson-Kaufman, and there are a number of others here on the slide, as well as Dr. Schiffman, who will be joining us tomorrow from Yale University. So thank you, everyone, for helping us put this together. So today I will focus on what the Office of Science Quality does and give you some information about that and the resources we can provide, and talk a little bit about guidelines and recommendations, and then turn it over to Dr. Kaufman, who's going to be the main presenter this afternoon, who will then run through the nitty-gritty that we want you to feel you can walk away with and be really prepared to jump in and make your guidelines a success. Here is a really brief, a really light org chart of the Office of the Associate Director for Science. And you may know Harold Jaffe is the ADS for the agency. And Dr. Ron Otten is acting as the deputy ADS. And then we have 3 offices within the Office of Science Quality. That's the office where the guidelines and recommendations team is located. We have the Office of Science Integrity, and Tim Barrett is the acting director there. And that's the office you may know because they focus on human subjects issues, animal safety and care issues, OMB Paperwork Reduction Act, to name some of the highlights. And then we have a new office, the Office of Technology and Innovation, and this is led by Dr. Julianne Anna Cyril, and they focus on technology transfer and innovation. And then we have another activity that's not represented here on the slide, and that's called the Special Projects Activity. And you all know Dr. John Iskander, who's with us in the audience today, who leads Grand Rounds. He's in that office, and a number of other projects are managed through that office. So what do we do more specifically in the Office of Science Quality? Well, this is the office that oversees the Excellence in Science Committee. And as you may know, this is a committee of center ADSs from across the agency that come together to work on difficult scientific issues, help create policy, scientific policy across the agency. And this is our information exchange venue. We also have a focus on creating science policies and guidance that will serve scientists across the agency. This is the office that also oversees clearance for the agency. So not only are we physically reviewing high-profile or highly controversial documents in this office, but this is also where the e-clearance mechanism and activity is maintained. And we have about 20 contractors that work on upgrading that system and keeping it running on a regular basis. This office also has oversight for a number of scientific awards across the agency. And then, of course, near and dear to everyone's heart today, the Guidelines and Recommendations team is in this office. So really, this office was established to increase the impact of CDC's research and science across the agency. We really focus on science quality, relevance, credibility, and transparency. And you'll hear those qualifiers or descriptives coming up over and over again during this afternoon's session. So up a little closer, this is the Office of Science Quality. There's my high school photograph. And we also have, we're very glad to have with us Dr. Barbara Ellis, who's in the audience. She's been with us a couple of months as the new deputy director. Very glad to have her. We have Dr. Vilma Karande-Koulis, who is a scientist and economist, and she leads the Guidelines and Recommendations activity, and really is a wealth of information on this, and I'm sure you'll hear from her at times during this afternoon. We have Dr. Diane Matson-Kaufman, who's a senior health scientist, and you'll be hearing most from her today as the main presenter, and she's been really instrumental in pulling this together. And then Dr. Jane Gadudu is a medical epidemiologist, an MD, MPH, and has a lot to contribute on the clinical side in relation to guidelines and recommendations. So this is our cast of characters, so you know who to reach out, not only this afternoon, but into the future. So now I'm going to talk a little bit about why our office, the Office of Scientific Quality, puts so much effort to improve guidelines. The goal of our efforts is to improve the transparency, quality, credibility, and impact of CDC guidelines and recommendations. We also establish minimum standards that we endeavor to have match standards outside the agency as well. And we also provide consultations and training of CDC scientists across the agency. Our improvement efforts include raising awareness, and you will find online, if you have not looked before, guidelines and recommendations, a CDC primer, and this is a good way to get some of the background about CDC guidelines. It presents some of the standards, and we also really focus on presentations and training opportunities across the agency. And that's how we go ahead and strengthen expertise across the agency as well. And we're always glad to consult and talk with people as you're beginning to develop your guidelines and recommendations, or if you're in the middle and you're just having a tough time and you want to run things by someone, we're the folks you want to reach out to for consultation and technical assistance. And then finally, we work to improve the rigor of reporting. So we want our guidelines to have the highest scientific quality and also transparency. It's really important for us to let people using the guidelines know where we got this information and why we stand behind it. And so this is where we provide scientific review and clearance of those guidelines documents. So improving quality of guidelines has been going on for quite some time at CDC, and I think the first time there was a concerted effort in doing this was in the mid-90s, 1996, and that was the first time a document was issued that ever addressed this. It was called Improving the Quality. And it was an effort to establish some common language and frames of reference. As you know, CDC started as a really small organization in the 1950s and has grown very quickly. And sometimes we're very used to doing things by just knocking on the door next door, and we didn't have standards across the agency. So this was one of the first efforts to take a look at that. And then in 2005, there was a quality of evidence work group that was developed. And this group got together to develop consistent institutional approaches to guideline develops, and again, increase the focus on standards and evidence. And then shortly following on that, there was also an MMWR effort to bring together folks to come up with some standards, and there began to be some standards of reporting when people were publishing in the MMWR. And then in 2010, there was a guidelines and recommendations work group, and again, scientists came together, started to identify needs. People were stumbling a bit at times, and again, a focus on CDC standards. And that brings us up to the more recent, where the primer was developed, that resource I told you about online, and the guidelines and recommendations activity, the small team of folks that I pointed out earlier, they began to take shape to be a resource in the OD to serve across the agency. And then since 2012, there's been an annual guideline training, and so we're so glad to have you at the 2014. The 2013 training was a definite success, and we had so many people on wait lists, and we're glad to be able to accommodate many of you this year. So I think this mentions a number of other things that I've already talked about. I just wanted to point out one of the resources in your folder that we'll be using this afternoon in training, and that is under the bullet standards, this checklist for reporting and clearing CDC guidelines and recommendations. And I view this as a multi-page cheat sheet. So we're going to train you from that today, and it's also a great resource as you actually start to put pen to paper or fingers to keyboard and move ahead in developing your guidelines. So at this point, I will stop and turn the podium over to my colleague, Diane Matson-Kaufman. Thank you.
Okay. Good afternoon. I like to start things out a little lightheartedly. So I'm Diane Matson-Kaufman, and this cartoon says if you read the guidelines, you'd see that all they actually recommend are a pair of rubber gloves. So we're glad to be showing you ways to try to make your guidelines not only good quality but also readable. And sometimes, you know, they're just so big that people don't read them and too cumbersome. And they're boring and long. And so what we want to help you do is to develop guidelines that are succinct as well as good quality, so that people will read them and do the right thing. So for those of you who just joined us and walked into the room, Neelam Gia, who is right here, Commander Neelam Gila, could you just raise your hand? Please see her if you haven't seen her yet, to get your attendance marked off, because we want to give you credit for attending, and also any other questions you have, see her. On the packets that you have, all the slides that we'll be going over today are in your packet, so you can follow along. They're on the back of your right-hand side of your packet. And you can also pull out the checklist that Joanne just referred to, because that is an expanded version of the slides that I'll be going through. So both of those things you can have in front of you. Two other documents that are on the right-hand side are the Diabetes and Driving manuscript and a document that says GLIA. Those are two documents that if you have time to read tonight for tomorrow's presentation and the hands-on part of the training, we'll be using those two documents for those exercises. And then on the left-hand side of your packet is the agenda for today, and you'll see that we will have breaks, a break at about 2:45, so that you can do what you need to do for 15 minutes. And then tomorrow's agenda, which will be held in the distance learning auditorium downstairs. So just so you know, don't come here, come downstairs. And then the evaluation, which is back as well. It's a one-page evaluation. We please ask that you complete today's session for today, that evaluation, so that we can get feedback that will help us know what we did well, what we could improve. And also it'll help give you the credit that you need for the course. So before I get started, any questions so far? Okay. All right, so I'd like to begin by first thanking our contributors before I move into the slides. Vilma, could you stand up, and Jane in the front row? I just want to, these are my collaborators, and they have really done the lion's share of the work with me to pull this all together, and greatly contributed to what you see in your slides today. So thank you. All right, so a lot of times it's good to start with a definition of what we mean by guidelines and recommendations. Sometimes people say, what's the difference? Well, there have been many definitions posed, and guidelines and recommendations can take many forms. We like to use the WHO definition, which is printed here, which is a document that contains recommendations about health interventions, whether they be clinical, public health, or policy interventions. A recommendation provides information about what policymakers, healthcare providers, or patients should do. It implies a choice between different interventions that have an impact on health and that have ramification for the use of resources. So bottom line, a guideline is kind of the whole package of recommendations, basically, of what your intended audience should do. So why should we develop guidelines and recommendations? Well, we know that there's a variation in public health practice, and mistakes are made because of that, and both in the clinical setting and the public health setting. So the intention is to pull together And there's insufficient use of evidence. So the whole thing starts with pulling together the synthesis of science in terms of what works. And then using that science, getting it out there into a form of a guidance or a guideline so that people will adopt the best science and evidence-based approaches. And then as a result of adopting that science, that will improve the quality of care that's delivered or public health interventions and ultimately improve population health. So that's the flow and that's the purpose of having guidelines. And the scope of guidelines at CDC covers a lot of different things. Surveillance can be a guideline, how to do surveillance, how to mobilize community partnerships, developing and implementing policies and programs, how to implement those policies, and how to evaluate certain types of services. So guidelines can take many different forms in terms of what to do, but also how to do it. And they're typically developed by a group of multidisciplinary stakeholders who use the scientific evidence to develop these guidelines, not just rely on their expert opinion, but try to look at what's out there and obviously collaborate with other partners, including federal advisory committees. Ideally, they're based on a systematic review, but sometimes the data isn't there, and so you use the best evidence that you have, and sometimes that's the gray literature and case studies and that sort of thing. There typically are guidelines at CDC are often published in the MMWR, but they're sometimes published in other peer-reviewed journals. And usually they're not mandatory unless they are made so by regulation or policy, like OSHA has regulatory guidelines. Now NIOSH, the National Institute of Occupational Safety and Health, develops the synthesis, develops the evidence, and then turns that over to OSHA, who in turn creates policy or regulatory guidelines for safety purposes. So that's how those two agencies work. And they may be issued under other names. The terms that I've heard and you've heard is best practices, promising practices. So sometimes we use different terminologies
modes.
Thing. But in general, they start out with sentences like CDC recommends. And that is usually an indication that a guideline is about to follow. So here are some examples of CDC guidelines that have been published fairly recently. Most of them have been in the MMWR, which is considered the voice of the agency. Some of them are short versions, and some of them are very long versions. And so sometimes you see a companion piece that's published in another agency because MMWRs are typically very short. And sometimes people refer to websites where you can get the guideline. The school health guidelines to promote healthy eating and physical activity, that's a very long guideline. Obviously, there was a lot of collaboration with schools and people outside of CDC, stakeholders, because those are the people we want to use the guidelines. And if you look down at the very bottom, the guideline for the prevention and control of norovirus, gastroenteritis outbreaks in healthcare settings, that was a HICPAC guideline recommendation that was developed with a federal advisory committee. So these are really a variety of topics, a variety of subjects, and a variety of places where these are published as well. So one good way to get a perspective on the guidelines we publish, we see the scientific piece, but what oftentimes the public sees and what we hope that they see is the bottom line message, or the SACO, the overriding communication message. And these are some of the news headlines that have appeared over the past several years in the media. CDC urges all Americans to get flu vaccine. Scientists urge CDC to revise lead exposure deemed safe in children. CDC says quit smoking with replacement therapy. So these are the bottom line messages that we want the public, if that's who our intended audience is, to see and to review and hopefully adopt. And again, they're the official voice of the agency, the CDC. So now I'm going to just turn it over to the development process, kind of give you a snapshot. And most of you, if you've been developing guidelines, this is not new to you, but I think it's good to start with kind of the overview of how the development process works or should work. These are some of the initial steps that we encourage you to think about before you even get started. Should a guideline be developed, regardless of who develops it? And these are some questions to help consider that question. First of all, is there a current or potential public health burden? Is there a gap in knowledge? Do guidelines on the topic already exist? And if so, are these deficient in quality? What will be new that is added by the guideline development effort? Is there sufficient evidence to develop these guidelines? And if no, is expert opinion available? And who is the intended audience? And do they think there is a need to develop these guidelines? Now, why would you think that these questions are important? Anybody from the audience? Why would you want to think about these questions? Anybody? Yes, Sandy.
I think you can avoid duplications and try to use resources more wisely if you answer the questions.
Mm-hmm. Right. Avoid duplication of effort and help people use the resources more widely because they're limited. Anybody else think it's important or have an experience why it might be important? Farrah? Mm-hmm. So it kind of gets at the purpose. It kind of helps to describe, help to define the purpose. And yes? Mm-hmm. After you develop the guidelines or before? After. Mm-hmm.
So I wondered about, even if expert opinion is available, you might want to do a systematic review to find out what evidence is.
Absolutely. Expert opinion is not good by itself. It's always good to combine it with a systematic literature review because both are good. Both are important. The evidence, obviously, and objective evidence is critical, but you also want experts who've been doing this work to weigh in on circumstances, applicability, how to make it tailored, how to tailor the information to meet different groups' needs. So I think they're both necessary. One does not replace the other. But sometimes if you don't have evidence for a particular topic, like anthrax or something like that, you need to rely on people that, that your best evidence available and your best opinions available. So they work together. It shouldn't be a substitute if it can be avoided. And if you have comments, if you don't mind telling me your first name, so that I can, try to remember you. I also just want to add yes, Joanne.
Thanks. I also wanted to ask that people remember to turn on their mics because you're raising excellent points and we want the remote audience to hear them too. So it's the little button on your desk that goes off and on.
Thank you, Joanne. Thanks for reminding us of that. Any other comments? Yes?
I have a question about the last one.
Mm-hmm.
So if the audience doesn't think there's a need, but it must be that they may not be aware that there's a need.
I think that it's important to explore why they don't think it's a need.
They might be doing something that they think is the right way, so they might not be aware of it.
Right. They may not be aware that they may be relying on their own practice. This has always worked. Why are you telling us something new? So it's important to have that dialogue with those people early on in the process so you understand why they don't think there's a need, and then they can also in turn hear from you why there is a need. So hopefully you come together and come to an agreement. Oh, maybe we don't need these guidelines after all. Did somebody else have their hand? Yes. Yes, sir. Tell us your name, too.
Jeff Beckett. Tremendous amount of work, very long process, very big commitment.
Yes.
We'll crowd out a lot of other work, and it really should be a good reason to do it.
Thank you. Amen. That's the reason. It's a lot of work. You'll see. If you've already been through it, most of you, so you know it's a lot of work. So you don't want to spend all this time and effort and then for naught. So, Farah, did you have another comment?
I'm part of Tier 3. I'm a health scientist at the Division for Heart Disease and Stroke Prevention. And I think these questions also helps us to see if the guideline is evidence-based or not. So evidence-based is very important.
Mm-hmm. Absolutely. And that's the talking point. That's our talking point. I mean, that is our linchpin at CDC, is focusing on the evidence rather than just the common practice that's out there. We have to make the case for evidence when we talk to our stakeholders so that we're all on the same footing. Okay, good comments. Thank you very much. And I want this to be interactive, so this is great. Second big decision step, is CDC the most appropriate agency to develop the guidelines? Does CDC have primary responsibility, or is it mandated by legislation or policy? Is the topic within the purview of other agencies? Does CDC have the expertise? And are sufficient resources available to develop the guideline, as this gentleman indicated? It's very time intensive. And then are partners available to provide the needed resources and buy-in? And again, it's good to pull in the partners in the beginning so that you get the buy-in and prevent the pushback that might occur down the road. Any comments about this or any experiences that you've had related to this, bad or good? Yes, ma'am.
I'm Liz from DHAP.
Hey, Liz.
And I guess I wanted to ask, who else would be the primary, who else would take the responsibility? United States Preventive Service Task Force or whom others? Because I think we're public health agencies, so we have a certain responsibility, but I'm just wondering whom else you would.
A lot of other federal agencies, and you mentioned one, the U.S. Preventive Services Task Force, ARC. There's, pardon me? WHO. Anybody else that you can think of off the top? Yeah. The question was, CDC's role is to do this work, public health guidelines. Who might be the other agencies that would be developing these sorts of guidelines? And we've been mentioning a few, like U.S. Preventive Services Task Force, WHO. Joanne, you had another one?
For clinical issues, professional organizations may.
Professional organizations for clinical issues. Yes, sir.
Stuart Berman. I say one thing for us to keep in mind, CDC, it goes back to actually when my daughter graduated high school, the head of the school, when he was giving the graduation speech, they were playing Nobody Does It Better. He waved them off and said, a lot of people do it better. Nobody does it longer. And I think we have to keep in mind some of these processes, are half a decade from start to finish when they get them out. And so, you really have to keep in mind when you embark upon this, with the processes that we often are stuck with, it is a very long commitment. And some of these things are changing while you're going through that. You go back and revise it. So it's almost like painting the Georgian Bridge. So I think that's one of the things to keep in mind as you embark upon this, to understand, are we the right agency if it's going to take us 5 years, perhaps? If you want to get something out quicker, it may not be us.
It may not be us, yes. And that's why partnerships are very important for that reason alone. The point about the time commitment to develop these, it takes a long time, and then the review process. Some groups are actually contracting the synthesis part of their development to other groups who are professional groups that do it well, and I'll be mentioning one of those examples later on. So, yeah, the evidence part, which systematic reviews take a long time. So if you can think about, should we be contracting this out? There are groups like the ECRI Institute that do things like that, and that can speed things up too. Any other comments? Yes, Sandy?
A question. How often do you think we should be revising recommendations? Sometimes when you review, you observe that the previous recommendation was maybe 10, sometimes up to 20 years old, and you're trying to figure out, should you still cite that recommendation, or has everything changed so much that maybe a new one is needed?
Mm-hmm. Yeah, the question was, how often should we be considering updating guidelines? And there is no pat answer. It depends. It really depends on the amount of new evidence that there is. I mean, maybe nothing's been published on the topic or substantial enough to make a change. But if that's the case, then you want to say that somehow in a statement that there's been no new evidence, or no, or if there's been a number of significant studies that have changed things, then the group may decide, okay, it's time to update these guidelines. How are we going to do that? How are we going to do that in an expeditious way? So it depends. It really does. There's no pat answer to that. But it's a good question to keep in mind. Should we be updating these guidelines? What's the rationale for it? Okay. And then, is there a plan for translating, disseminating, evaluating, and updating the guideline? Right now, we're doing a pilot project now with some guidelines that have already been published to find out whether they are doing any of this, and some of them just aren't. A lot of them, people that have published guidelines say, well, once we get them published, that's it. It's out of our hands. But now, there's a whole big emphasis on translation of science to practice. How can we do a better job of translating guidelines into usable formats such as charts or short clinical decision supports or things like that, so that people actually use them? How can we better disseminate them? Not everybody reads MMWRs or long peer-reviewed journals. Webinars is a way to go a lot of times to get things out there, or doing zip alerts to get information out there quickly to people. And evaluation is usually not even on the radar. Is it making a difference? Are people picking them up? Are people using them? Is it making a difference in their practice? And is it ultimately improving public health? Those are the things that we should be building into our guidelines down the road. Now, many of you, by the time you're done with the guideline, just don't want to see it again. And so, it just kind of, that's it. I've done my job. But that's something where, again, you need to be thinking up front, how are we going to... And that's the question, that how often should they be updated, too? That's another question that should be answered in the beginning of the process. And do we have the sufficient capacity to do all these activities? And again, that's where partners come in. Any comments about this? So, yes, sir.
Andy? Raise issues such as whether there ought to be some central resources that can help in these kinds of activities. A couple of things come to mind. One is registries of guidelines, for example. Someplace you could readily find out if other groups are likely to be working on a guideline at the same time. Another has to do with this effort to move towards web-based guidelines, which are more easily updated. But that requires a fair amount of resource and maintenance.
Mm-hmm.
And so is that something your office is looking into in terms of trying to offer support to divisions?
The question has to do with, is there some kind of a registry for guidelines, and is there a central place for support of guideline development? Vilma?
Yes. ARC has, with the ECRI Institute, has set up what is called the Guidelines Clearinghouse, the National Guidelines Clearinghouse, NGC. You can look it up on the internet, and has a repository of many guidelines in the U.S., including CDC guidelines. And also the interesting part about the National Guidelines Clearinghouse is that they have a standard method of summarizing all the guidelines. So you can see there what it is important for summarizing guidelines. Each guideline, you can do a query, you can look for any kind of guideline you want, and then you can see how it's summarized and standardized. Everyone is summarizing the same way.
Is that a searchable database?
Yes, yes.
The National Guideline Clearinghouse is the database, and not all of our CDC guidelines are in there. They have really high standards for getting published in that. So, but yes, you can just Google it.
So if you do a bad guideline, it won't even get listed in the clearinghouse.
Well, if it was possible for us to do a bad guideline, we might capture it in CDC stacks, where we archive the CDC guidelines and also curate to try and keep up with the most recent version. So that's another checkpoint, but that would be internal.
Do you have an estimate or other kinds of data on the costs of guideline development?
The question is, do we have an idea about an average idea about the average cost for guideline development?
Yeah, I would say the only place where you could get some idea of cost of guidelines would be the community guide, because they have been doing, although they do the systematic reviews and the guideline and the recommendations, but they have been doing it for so long, and also they have economists on board. So I do not know whether they have. I remember when I was at the guide that I did calculate the cost of a guideline, and it came, but this was like 15 years ago, but it came around $500,000. But now I am sure it can easily go to $1 million or more, because if you just count salaries, and a guideline takes from 6 months to 5 years, so, you know, depending on how many personnel you have, how many meetings you have, all that.
Yes, sir.
I think you have to define what you mean by a guideline. I mean, there's several of these that the U.S. Preventive Services Task Force contract with EPCs are a single question guideline, answering one question: should you be screening for this or that? But several of us, as you know, across CDC, doing guidelines that address dozens of questions. Dozens of questions. Right. And so, you know, it's hard to compare the cost, because they're done in a different way. It's a different process. The process and the objective is different. So it's under that same word, you have very different kinds of.
Yeah. So the point that, you know, if you cover a myriad of questions in your guidelines, yeah, it's gonna cost a lot more than if you're focused on one question. So good point. And that brings up the point in the development process is always craft your questions out that you want to study in your literature review, so that you do have an idea of what it is, the kind of resources you need. So let's move on. Okay, so now you've done all that. You haven't even started yet, right? But you've asked some good questions about should we even begin. Once you've answered these questions, then you got to determine the topic and the need and the purpose. Get those clearly stated. Get the purpose clearly stated so everybody is all on the same page. And then you need to identify your audience and your settings. Who are the people that we want to reach? Who are the people that we want to bring in as partners? And what's the settings that this guideline is going to be directed to? Is it going to be a clinical setting, a community at large setting, work sites, schools, all of the above? I mean, what is the particular setting that you're directing your guideline to? And then identify your contributors. Who are the people that have the experts, expert opinion, the experts in the field, the stakeholders that you want to get on board with you, the people who will oversee the development process. And then the work groups, those are the people that do all the work. Again, you want the people with the right expertise. It could be a center-based group that's out of your center working with other people outside, or it can be an independent task force like the Community Guide. They're commissioned to do this kind of work, or it could be a federal advisory committee. So those are the kind of the three mechanisms that we use that are used here at CDC. And the federal advisory committee are groups like ACIP, the Advisory Committee on Immunization Practices, and then the HICPAC committees. Then what are their informational and training needs? Do they have any? What are their roles and responsibilities? Oftentimes, we can't pay them, so we need to be very clear what we expect them to do, and you might have different work groups working on different pieces of your guideline. And then we have a requirement for competing interests, which everybody needs to sign, and I'll talk about more about that later. And then you brought up the point already, how much time and resources are going to be needed, and you try to get an idea, an estimate of how long this is going to take. This is a graphic that conceptualizes the steps in the development process. It comes from the 2011 Institute of Medicine report on clinical practice guidelines we can trust. And although this focuses on clinical practice, the similar processes is applied to other guidelines that are not clinical. So basically it starts right here. A group comes together and says we need better evidence and guidance to make informed healthcare choices, or the guidelines are outdated, we have new evidence now. But basically that's where it all begins. You have a defined problem or a defined clinical problem in this case. And then you assemble your team, and this whole process here has to do with identifying the evidence, synthesizing the evidence, and producing this systematic review report. Before you even get into the guideline development process itself, it is developing the literature synthesis. And then once you develop that report, you have a group that appraises that evidence, looks at what it says and other evidence that comes out from practice, and you incorporate your expert opinions, and in this case, because it's clinical, you consider patient preferences and characteristics, and then you produce your guideline, which is right here. Now, oftentimes what we see is there's a gap between the systematic reviews and the guidelines. You've got this systematic review, someone's looked at it and it sits on the shelf, and then these people come together and they don't even consider it. They feel like they know it all because of their practice. And that's one of the things that we look for, is a link between these two things. So we won't clear guidelines if there's not a link between the synthesis of the evidence and the literature evidence and the recommendation. So that needs to be done. And then this whole area of clearance, there's different levels that you know about, I'm sure, both in your division, in your center, and then if it's highly sensitive, and it comes to our office before it's even published. So this is basically how the whole process works. So let's go through this process in a little bit more detail. First, you have the work groups that identify the best available evidence, and it's interpreted in the context of practitioner experience, conditions of the intervention, how it gets implemented, different settings, and the people who are receiving the guideline, the end user, the people who will not just use it, but the people who are the recipients of the practice or the guideline. And so all of those that's where your experts come in, is considering all these kinds of, the context of the guideline. And then you look at your methods that I'm going to address in just a minute, and they vary. But some of the things that we look for is a really good search for the evidence, and that needs to be reported. You have a search protocol that identifies what sources and databases you're going to use, like PubMed or Ovid. You define your criteria for inclusion into the data that you want to look at. For example, you may only be interested in certain methods, or you may only be interested in a certain type of intervention, or many of the interventions might be just focused on a certain population. So that's the kind of criteria that goes into your search. And you may just be looking at, want to look at studies that have control groups. So that's the kind of criteria you want to identify when you do your search protocol. And then what kind of an abstraction form are you going to use? And there's many forms that are already developed. The GRADE and the Community Guide have electronic forms, so please don't reinvent the wheel. Use things that have already been developed and are out there for abstracting your data. And of course, we encourage at least two people to abstract data together so that there's accountability and accuracy. And document your search process. That should be listed in your methods and how you selected your studies. You can have criteria for both selecting the literature you look at and also honing in on the types of studies you abstract, because abstraction takes a long time as well. Then you extract the data from the studies and put it in a table format or some kind of a format, and there are databases that are developed. Again, GRADE has something that you can use, a software package that you can use that will help you manage your data.
The Cochrane collaboration also has a software called RevMan, R-E-V-M-A-N. Many of you probably are familiar with it. That allows you to summarize data that then you can import into GRADE.
Mm-hmm. Okay.
GRADE has another software that is called GRADE Pro, so you can export the data from RevMan to GRADE Pro.
Okay. Yes, John?
Follow-up comment to Vilma's, which is that both within the CDC library as well as in other parts of the agency, there are individuals that have special training in conducting systematic reviews, and so they can be either those can be requested from them or they can be consulted as part of the process.
Do you know how to access those folks?
Yes, correct.
Yes.
The library has made an effort, just adding to a little bit to what John said, at the request of actually was initially the Community Guide and then us, to specialize folks in this type of searches. So they have one person, and I believe they were training another one. So the library, folks, is a great, great resource for literature searches. But make sure that you have your protocol, your search protocol, well defined before you go there.
Okay. All right. Good comments. Any other comments? Yes. And I'll be highlighting what Vilma just mentioned later in the slides on tools. Yes. Nancy? Nancy?
Right here? Okay, yeah. So we're using EndNote because that's what the library has, but we've worked with RefWorks as well, and then there's RefMan also, but I didn't know that we had that availability here in CDC. I thought we had to use EndNote.
The availability at CDC is to do the literature search, not the abstraction or not the selection of the studies. Only doing the search, and they will give you a list of citations. Basically, that's what you will get, okay? The abstraction is a selection of the studies from the body of literature that has been extracted. Is a different process that the work group, the development work group, will have to do.
No, I understand that. I mean, we've done a number of systematic reviews now. We've done them with external contractors and also external professional organizations. So the last one we did, we used RefWorks to organize all our literature, and we worked right in RefWorks with our abstractions, added everything to that. When we started doing an internal one here at CDC, the only thing we had available to organize our papers was EndNote.
You can download RefMan and RefWork and RefMan from the Cochrane collaboration, and also from the same site you can download Grade.
Okay.
Grade Pro,
Well,
excuse me.
We have the
Grade Pro.
link in one of my slides.
Do we?
Yeah.
Okay, great.
And I'll show you how to access it. Okay, so yeah, EndNote is, the point was, there's more than just EndNote at our availability to use. And I will show you some of those resources, okay? And, you know, finding them is, you know, sometimes hard. Okay, so summarizing the evidence, then basically once you, lights here. Okay, once you've done this, then the synthesis and the narrative of the evidence is the next part. You want to synthesize the primary outcomes of your data, the benefits and harms, and the economic efficiency. That's the cost benefits, the cost effectiveness, if there's data there. It's not enough to just put it in a table. We want to see you write about what's in the table and summarize it. But the tables and the graphs help you to refer people to data. If the paper's too long, the tables are too long, you can put them in a website and refer people to that website. But typically tables are useful for synthesizing or abstracting your data, and graphs are very useful for summarizing your outcome data, such as through effect size and forest plots. I think both of those things are very useful. And then assessing the quality of the evidence, I'll talk a little bit more about that, because quality is a big, seems to be an area where people get confused about. But that's good to talk about how you assess the quality of the evidence. And then we had some questions about how do we best solicit expert opinion when developing guidelines and recommendations. Experts are useful for filling in the evidence gaps, particularly when there's no evidence available. And sometimes guidelines and practice-based evidence is really important. It informs the literature evidence. So the two should come together. And sometimes you have to rely on experts when you're in an emergency situation. We've seen a lot of reviews pertaining to anthrax treatment in our office, and obviously there's not going to be much evidence around studies using anthrax, and so, because it can be considered an emergency situation, you know, you have to pull together the best evidence, and animal studies are a good proxy for some of that evidence. So when there's a need for addressing things like that, you've got to rely on your experts. And then we also want to see how you used your expert opinion. What kind of methods did you use to gather opinions? Did you use Delphi, the nominal group process, Glaser techniques? These are the different processes that are available for organizing feedback from your experts. And please feel free to contact any of us about these techniques. That's what we're here for, to provide that kind of consultation. Okay, minimizing competing interests. When developing guidelines, it's important to minimize the influence of personal interests. This is often referred to as conflict of interest, but that usually refers to, that has legal and regulatory implications, and it just refers to financial conflict at times. We use the term competing interests because it's broader in scope and goes beyond financial. There could be intellectual and professional interests that could influence consideration of the scientific evidence. For example, a work group member receives research support from an organization whose product is discussed in the guidelines, or a guideline is a critical review of a person's individual work. It may be their dissertation, or it could be a number of things that influence an individual's objectivity and the interpretation of the results, and creates an unfair competitive advantage for any person or organization. So this is a big critical issue. We're doing more work on this, trying to educate people why it's so important. And It doesn't mean that competing interests can't be there. They just need to be disclosed and disclose how they were handled. Transparency is really the name of the game, and to prevent any kind of problems down the road. And there are special regulations, as you probably know, for federal and special government employees through the OGE 450 form and the OGE 278. That's separate, that's regulatory, and that is handled by those groups. But what we ask for is a competing interest statement, and I'll discuss that more later. Okay, this is a headline from the New York Times that illustrates the importance of attending to conflict of interest. This story focuses on the financial ties that some participants in the clinical practice had with drug companies. These are three major guidelines that were published, one for hypertension, one for obesity, and one for cholesterol, and I'll just focus on the obesity one. It says, an NIH obesity panel is writing new clinical guidelines on the identification, evaluation, and treatment of overweight and obesity in adults. Its predecessor in 1998 changed the definition of overweight to a body mass index of 25 instead of 27, reclassifying 30 million Americans as overweight. Well, NIH got into a lot of trouble with this one. These red bars here indicate competing or conflict of interest, and one of the two chairmen had a conflict of interest. And these are all the academic members, and just about half of them had conflict of interest as well. So, and I'm not sure that they were disclosed, but just the fact that this was, they changed the reclassification, and I don't believe there was disclosure of these kind of competing interests. It became a headline, and that's what we're trying to avoid. Yes, Chris? I don't know what it was. We don't know what the conflict was. I didn't examine it. I just. Financial ties. Okay. Yeah, and we see a lot of in our office. We see a lot of new vaccines that are part of guidelines, and obviously there's going to be a lot more potential conflict of interest because a lot of the people who are on the panels get money from pharmaceutical companies to do their grants outside of CDC, so it's there all the time. And so we do put our foot down on this one and ask that they be disclosed for not just authors, all contributors. Any comments about this? Okay. So how can you handle these kind of interests? Well, you can recruit members that don't have them. That's one way, is to assess right up front before they're involved. Obviously, you want to have them complete a form to see if there are any competing interests that conflict with the guidelines you're being developed. And then you can decide, there's different ways to handle it. The participant could eliminate their conflict just by just not participating in whatever grant that they're doing. Or you could allow participation in some activities, or allow participation in not excuse them from participating in activities where conflict is greatest, or excuse them from participating in it at all. So it just depends on the situation and what's being discussed, but that should be reported in how it was handled in the document, in the manuscript. Okay, so then, the process, you've done the evidence, you've searched, you've synthesized, and now you're developing the recommendations. And group process is generally engaged in the linkage between how the evidence links to the recommendations. We want to report on how expert opinion was used, and even values and preferences. You may have a group that or a person in the group who has strong opinions based on their practice, and those are what we consider values and preferences, and those need to be reported and summarized. The recommendations are then drafted, and there may be a need to a report on the strength of the recommendation. You may have a lot of strong evidence, and so you can report with confidence that this is a strong, highly, evidence-based recommendation. Or it may be a weak recommendation. The community guide does that. They sometimes even report a weak recommendation based on weak evidence. So read some of the community guides and you'll see some of their statements. And assess the barriers to implementation. They can be resources, cost, feasibility, all kinds of things that go into getting this out there. And then write that into the report of your recommendation. Once you develop your recommendation, then the process of vetting and clearing comes in. And this could be with internal subject matter experts and CIOs, but it also is often a good idea to vet it with partners externally, key stakeholders and partners, particularly for guidelines that have influential scientific information, or ISIs. Highly influential ISIs are those that have an impact of at least 500 million or have a precedent for setting for policy. Therefore, you do definitely want to get vetting for those kinds of guidelines. And then there may be an interest in obtaining public comment. There's a lot of advocacy groups out there that will that have a lot of power in the community, so we want to engage. That's the reason why we put federal registers together to get public comment. And then, of course, the clearance process with your CIO, and sometimes cross-clearance if the guideline covers more than just your center, and sometimes even at the HHS level, clearance may be needed. And I'll talk more about clearance at the end of the session today. All right, I'm just going to pause here for a minute, and then we'll go into some of the tools and services that we have available. Any comments about the development process? Yes, Sandy?
Sandy Steiner of PHPR, and my question is about provisional recommendations.
About what?
Provisional recommendations when you feel like maybe your evidence is not that strong, or you could just issue the provisional recommendations?
A provisional guideline?
Or a provisional guidance?
Mm-hmm. What's your question?
Well, the question is, what can you give us guideline? What will be the parameters to be able to separate between provisional versus a true recommendation?
I don't know if there's any difference in terms of the expectations. I still think you want to, it's preliminary, it hasn't been published yet, or you're just saying you're waiting for more evidence, or?
Well, like if there was no federal advisory committee participation, or, are there certain parameters that could help you discriminate between, this is a question that comes to me because I have to deal with clearance of the documents when they come to me. And I am questioning sometimes, should this be a true recommendation or should be a provisional recommendation? How strongly can you make these recommendations?
Yeah. You want to answer that?
I think there are several factors in provisional recommendations. One factor is it may be that it's a fast recommendation that we need to get out. And there is not much evidence, or there was no time to gather the evidence, or actually there is no evidence in case of, we need to get some pandemic influenza guideline out there. And so that is a provisional, meaning that, well, this is like a fast guideline, and then we are going to have another guideline that will gather evidence and look at the quality of the evidence and all that. That would be a provisional type of. Another one is the quality of the evidence. If the developers of the guidelines are not satisfied with the quality of the evidence, it can be provisional until we have better evidence. But I don't think FACAS or not FACAS influence that, because we have a lot of guidelines produced not under FACAS.
And I'd like to add, if you're having challenges as a clearance reviewer working through some of this, that we're glad to consult with you.
Yeah.
Mm-hmm.
Yeah, every situation is different, and so there's sometimes no one answer. We have to look at the situation, and I think that's what would be best here. Yes, somebody else had a comment?
Yes, I have a question, Gemma Dumitru, DHAP. Currently, we are using our own conflict of interest form, so I wanted to know if you are planning to develop a standardized form. And second question, do we collect from internal members, from CDC people, a conflict of interest? Because we did so far, and some people don't want to provide. They say, oh, we don't have any conflict. So your thoughts on that?
We are aiming to develop a standardized competing interest document that will not have regulatory ties to it, but it'll be for purposes of clearance in our Office of Science Quality. And a lot of people want that, because they don't want to reinvent the wheel. And we do recognize that a lot of people don't want to fill out competing interest statements. But we have to reassure people that it doesn't mean that by doing so, even if you have competing interests, it doesn't mean that you can't be involved. We just have to know how we're going to handle it so we can minimize subject, problems like that we saw. Does that answer your question, Vilma? Did you want to add to that?
Yeah, I would like to add that we have been working with MASO in developing something that we don't end up violating any other act that could be violating. We do have, but we are not distributing because of MASO, the reason. We have a questionnaire that we think that we are not violating OMB requirements or whatever other requirements. We are going to provide guidance shortly. Now, MASO has developed policy for work groups under FACAS, and it's in draft and it needs clearance, but the policy has been developed. Now, when we talk about competing interests, mainly we talk about those members of work groups who are not CDC employees. CDC employees are covered by the standards of conduct and also are covered, if they are GE 450 filers, they are covered by that too. So when we talk about competing interest, it's not CDC employees or not federal employees.
Does that make sense to everybody? Okay. So MASO handles FACA groups separate from what all the other groups are doing.
Yeah, but we don't have the policy yet. They don't want to share the policy with us because it hasn't cleared yet. But as soon as we have the policy, then we will be able to provide more guidance.
Okay. Yes, ma'am. Say your name, please.
Push at the bottom.
Okay, sorry about that. Hi, I'm Sundari Mace, Division of TB Elimination. I wanted to know if you're going to talk about the pros and cons of including a federal advisory committee and what that entails sometime in the presentation.
I wasn't planning to talk about the pros and cons of using a federal advisory committee, but we have. Vilma, do you want to address that?
I don't think we have the expertise here.
Yeah, it's not FACAS. If you want to know about FACAS, you want to consult with MASO. Basically, FACAs, what I know about FACAs, they are formed for a purpose, and they advise the CDC director. Now, the advantage of doing guidelines under FACAs or not under FACAs, I could get back to you later, but I just don't. Some FACAs are very good, and I won't mention names. Others are not that good. But they have a specific area, like ACIP is vaccines. So if you're going to develop guidelines on something else, or HICPAC is about hospital infections, so healthcare facilities infections. So it has to be specific about a certain area.
Mm-hmm. So the question about the pros and cons of using a federal advisory committee, we don't know. It's best to talk to MASO about that, address that. But we could find out a little bit more about that later. Yeah,
in general, CDC does not want to form more FACAs. That's what I have learned many years ago.
Well, the other thing to consider is that there's standing committees that weigh in on a regular basis on ongoing activities. So we wouldn't pull a FACA together to develop a guideline and recommendation, a one-time effort. Right. But if you are developing something that's related to one of those FACAs, they likely would be involved, and maybe that's the simplest way to approach it.
Okay. Good point. Any others? Yes, in the back.
Hi, this is Pat Sweeney from DHAP. My question had to do with assessing impact. One of your last slides talked a little bit about that, but particularly the economic impact. And I was wondering what guidance there might be on, I don't know where it was, but when you're talking about scientific information and, what is a reasonable assessment of the impact? And I was wondering if there was any guidance on how complete or what areas, particularly when it's, in some cases, it may be, programmatic as well as the cost of certain interventions. And I was wondering if there was.
So you're talking about cost impact?
Yeah, well, in particular,
your question about cost
impact, yeah.
Okay. And Vilma is an economist, so I'm going to defer it to Vilma again.
I will tell you. Consult with the ADSs, but I will tell you the first thing that I always said when I conducted training on economics, and I ran the health economics program at CDC for 4 years. The first thing is hire an economist. Do not do it yourself. You think it's easy, it's not easy. We go through a PhD program, which is very, very challenging, and it's not only about cost effectiveness and cost benefit is not cost. Big difference. That's another thing that I always, make sure. But there is a course online on evaluating interventions for cost effectiveness. So I can provide, if you're interested, send me an email and I can provide the link. When I was the chief of that branch, we developed a course online. Now, apparently, the office of the Associate Director for Policy is trying to improve it.
Yeah. So, economy evaluating cost is the hire economist. There are many economists at CDC that you could also consult with, including Vilma.
There are 70 or 80.
70 or 80. But before you do any kind of cost evaluation, you have to collect cost. That's the first rule of cost analysis, is you have to collect something related to cost, or else you can't do it.
And also,
I know that much.
You have to have good effectiveness data. That comes from epidemiologists. If you don't have good effectiveness data, you are not going to have good cost effectiveness information. And that is a challenge, very, very often.
Yes, sir. What's your name again? I'm sorry.
Andy Vernon.
Andy, thank you.
I am wanting to go back a little bit to the issue of FACAs, but not with a more detailed question about FACAs, but rather a question about the area where we, at least in my experience, have tended to encounter problems in this regard. It has to do with what we're asking the participants in a guidelines development activity to do. And we are often told that if we're asking this group to provide us advice and come to some agreement on what they would recommend, that we are de facto constituting a federal advisory group, which we do not have the authorization to do, and therefore we get wordsmithed around the issue of concurrence of the group versus provision of their independent opinions. On the other hand, we're also, of course, logically and strongly advised that we should have outside participants helping us, assisting in the development of some of these products. So the question is, the path you've suggested here sort of avoids the question by having the guideline developed internally and then having a process that seeks input outside, from the outside in, at a subsequent stage of the process. What often happens at that point is you get back comments like, why didn't you involve us earlier on in this process? We have a lot to contribute. And so I'm wondering what counsel you would offer in that aspect. Or maybe this is too detailed a question for this point in the course.
Well, no, I mean, it's a good point, and I think that's where assessing competing interests comes in too, to, you know, avoid some of that concern that you may get from the outside of you're bringing in people that are going to judge it unfairly, judge the data unfairly. I mean, I don't think there's one right way to do it. You know, you want to bring in people that have the expertise, but you also, I think it's good to keep the synthesis part of the process, the data part separate before you bring in the experts from the outside, because the data speaks for itself, or should speak for itself. And then you bring in the experts to weigh in based on their experience. So, I mean, I think that's the best process for, before you get to the recommendation part, right after you do the synthesis of the literature, and then bring them in for weighing in on their, on the evidence that you've put together. Is it, Vilma?
Yeah, we are not prescriptive. When do you bring the experts, the outside experts? We really are not prescriptive. You may want to choose to bring them at the beginning, for example, in the case that you are going to develop the questions for the systematic review. And in that case, it would be very interesting that you have input from experts, from SMEs. So you may choose to bring them early. We are not prescriptive. When do you bring the experts? What Diane was saying is that the evidence gathering and the evidence summary and analysis is a different process that will be presented once it's summarized to the SMEs.
Andy, I want to acknowledge that your question touches on some of the federal regulations around these sorts of things. And I don't think we have enough information here, but we'll do some checking in that. I think it'll involve some conversation with MASO to get you a more solid answer.
All right. So we don't have all the answers, but we'll do our best to find them. Okay, so I want to share with some of the tools and resources we have available to you before we take our break. The principles and standards that we have in our checklist are really based on the primer that Joanne introduced earlier. The CDC primer was published in 2012, and it's available on our website. And it's designed not just for you, but for all work group members, outside experts who are involved in guideline development. And I think that the more we share about our requirements and our expectations with groups that we intend to bring in, I think the better and cleaner your guideline process will be. We have a wiki that has all of our information and services from our guidelines and recommendations team. We have consultations that we can provide to you at any stage of the process that you're in guideline development. Some of our policies and readings, resources and tools, and of course our training. The trainings that we're doing today and the last couple of years are posted on the website. Even the video cast from last year's training is there, and this is the link. As I said, we're available for consultation at any stage of guideline development, not just at the end when you have developed your guideline and it's ready for review in the clearance phase. Actually, we encourage you to talk to us before that to avoid some of the problems that we do see when they get to clearance, so that we can guide you on some of the methods that you're using and some of our requirements, which we'll talk about more in our checklist. And we're also very open to your feedback on what would be helpful to you. Last year we had a similar training. Dr. Schiffman did the training on enhancing clarity and transparency of public health guidelines, and that's posted on the intranet and internet so that you can share that with your external partners. And then 2 years ago we had more of a focus on developing your systematic review, which is also posted on the web. We mentioned a number of times about resources to help you rank the quality of evidence and the strength of your recommendations. The GRADE working group is an international collaboration of scientists and health professionals who have developed scientific and transparent approach to developing recommendations based on systematic reviews. GRADE provides help in clarifying your research questions, determining outcomes of interest, how to move the evidence from evidence to a recommendation. And GRADE approach has been adopted by 50 organizations worldwide, such as ACIP uses GRADE, and so does HICPAC. And many other centers at CDC are using this approach, such as the Division for Viral Hepatitis. The Cochrane collaboration created, and Vilma mentioned this, created a program called GRADE Pro, which is a software used to create summary of findings tables for Cochrane systematic reviews. And you can find those on these websites right here. And the U.S. Preventive Services Task Force Guide to Clinical Preventive Services also has tools, as well as the community guide. So there's no one right way. We don't say one over the other, but these are 3 places where you can search for tools that will help you in your guideline development. Other tools that we have available to you are BridgeWiz, which is an online tool that assists authors in developing more comprehensive guidelines and clear, actionable recommendations. And Dr. Schiffman will be demonstrating that with you tomorrow afternoon. GLIA is a PDF that identifies obstacles to implementation that are within the purview of guideline developers, and it helps you to identify and anticipate obstacles before a draft guideline is developed. And Dr. Schiffman will also be demonstrating that tool tomorrow afternoon. GemCutter takes guidelines a step further. It's a IT tool that translates a document into a format that can be processed by computers. So essentially it cuts a guideline into a clinical decision support system. And so you may already have your guideline and now you want to get it into the hands of the user, such as a clinician at a hospital, and it helps put that into a format that they can use online. So both BridgeWiz and GemCutter are approved for use on your CDC desktops, and you can request it by going to this link listed right here. And you don't need a government license to use the software. Okay. Additional materials that are available. There are many groups and organizations that are out there that focus on guideline development listed here. Again, we have a resource on our wiki that provides more information about what these organizations have available to you. Just for example, the Cochrane collaboration has a manual that takes users step by step through conducting a systematic review and has software development will assist you in analyzing and reporting your findings. Also, the National Institute of Clinical Excellence in the UK. Where is that? I'm missing that. Thank you. Why am I not seeing this? There. Thank you. It's too close. They have a manual that details the development of recommendations in health from start to finish. So there's many different groups out there that have their own processes. Look through them, see which one fits for you and for your needs, and please don't reinvent the wheel. That's the thing that we are trying to help people avoid. Adapt things that you can adapt, certain tools that are out there, but don't try to develop something from scratch. All right, so I'm going to just stop here right now before we get into our checklist. This is a draft tool. I think we're on time here, aren't we? Yeah. Okay. This is a draft tool that we've developed that we'll go through step by step, and I'll ask for your interaction. It's in your packets. And you can pull that out, and we're pretty close to being on time now, so I'm going to take just a few minutes to pause and see if there's any questions so far, and turn it over to Neelam. Did you want to add some comments too?
Questions from the audience first.
Okay.
Or even on the phone. Do you have any questions?
Are there questions from the live audience? Yes.
Has there been any thought given to, Amrita Taylor from Division of HIV/AIDS Prevention. Has there been any thought given to creating a repository where other groups in CDC that are working on guidelines could share the tools that they've developed, whether they've adapted them from some of these sources that you've mentioned? Oftentimes, these organizations such as GRADE and the Community Guide, their tools are much more rigorous than that fits our needs. So I know in our division we've done a little bit of that, and I'm just curious if some thought has been given to collecting that from others so we can share with each
other. The question was, have we considered putting a repository together of guidelines from CDC and the methods that have been used by different groups at CDC?
So
and
for
the tools
example,
that they've
the
used.
abstraction tool, the inclusion-exclusion criteria, how they evaluated the body of evidence, sort of their rating schema.
No, but that might not be a bad idea. I think the best thing to do is we have stacks, the CDC stacks that have guidelines listed, and other than just going through the guidelines and reading them themselves, I don't know another way to quickly capture what different groups have used and what tools they've used, and but we can discuss that. That's a good point. Joanne, did you want to add to that, or Vilma?
That's usually reported in methods, and it's very, very important to have a very complete methods section. And I don't know if probably Joanne's going to be tapping my shoulder, but my arm, but until 3 years ago, we used to get guidelines with no methods at all.
Yeah, so people are getting more sophisticated and writing up their methods, and I would just refer you to the community guides and review some of the more recent ones and the methods that they use. But I understand what you're saying, that sometimes they're more sophisticated than what you may need or do. So other than reading them, we haven't compiled that, but that's something we'll discuss. Good. Yes.
We have found that some groups have adapted, for example, GRADE. And I am assuming they adapted it because just for reasons of being more manageable or simpler or whatever. So we have those guidelines.
And when we talk about our checklist, we're going to showcase some guidelines that were segments from different guidelines that were written very well. So that'll give you a head start, at least looking at those that were done well. Yes, ma'am.
Yes, could you just reiterate what the gem cutter does? I didn't quite catch it.
Okay. It's you'll hear more about it tomorrow. Hopefully you're coming tomorrow. But basically it takes a guideline and cuts it up into segments that a computer can understand and read and interpret and put into language so that when a user gets the guideline, they're put into a clinical format. So let's say you're a practitioner and you're delivering care to your patient on hypertension control. It will say, if you do this, if the person has this condition, then prescribe this type of treatment, physical activity, nutrition, medications. So it basically takes the guideline and cuts it into a usable format for the user. That's the simplest way I can distill it, but you'll hear more about it tomorrow. And it's a lot of if-then statements. If this, if this, if this, then do this. So that's how guidelines should be written, basically. Any other comments from either the live audience or nobody from the live meeting has questions? Okay. Neelam, before we take our break, Neelam has a few announcements.
So those who snuck in the back door and didn't sign the attendance sheet, please see me up front so we can get your attendance. We're going to pass around some chocolates, but get up, move around. Let's come back at 3 o'clock and we will regroup then. The restrooms are down the hallway to your right. Thank you very much.
Dark talk. Healthy. Doing guidelines, and so I really appreciate your sharing us your experiences, your lessons learned, as well as your questions. I don't have all the questions. I've been in this office for just 2 years now, so I don't claim to have all the answers to your questions. So we can always say we'll get back to you. So I do defer to some of you in the audience who may have more experience than I do in sharing your lessons learned. So please feel free to do that. I'm going to zoom through these slides because I'm a little bit behind, but don't worry, we'll get through it all and we'll still get to your questions. So if you want to go ahead and take out your checklist. Neelam wanted to just make a few additional housekeeping points.
Sure, we have quite a few participants on the remote and live meeting, and so please remember to, again, press the push button on the microphone where you're seated, and then when you're done speaking, please press it again to turn it off because the people are hearing background noises. And I think that was it. Thank you.
Mm-hmm. Yeah, and I'll try to repeat your questions for the live meeting audience. This is the checklist. If you can pull it out, then you can go along with me. Please note that this is a draft form, so it should not be distributed outside of CDC. We wanted to get it to you. This is fresh off the press, but we will be using that when I go through this list. The checklist, as I mentioned earlier, comes from our primer. It's basically operationalizes the CDC primer, and we consider it the minimum standards for guideline development. You'll notice that each item has a check. Some of the items have checks by them. That means it's critical. That means you have to address those items when they go through clearance. And the last thing we want to do is to turn back guidelines that are not adequate. So please pay attention to those things because sometimes key information is missing or it's unclear. And we do use this checklist when we clear documents. This isn't brand new. This isn't rocket science. This is information that you probably already know. These are standards that are used outside of CDC with organizations such as the National Clearinghouse for Guidelines, which was mentioned earlier. So this is not something that we just came up with. And as we go through the slides, I'll refer you to the page numbers that have the longer description of the examples that I'm going to show. There's 7 sections in the checklist describing scope and purpose, reporting on participants and competing interests, describing the methods used to obtain and summarize your evidence, reporting on the recommendations and describing your methods used to develop them, describing future research needs, and describing, reviewing, and your vetting process, and your updating approaches. So we've talked about the development process. Now we're going to talk about some of the things to report on in your guideline document. Okay, the first section describes scope and purpose. This is intended to tell the reader why you're developing these guidelines and the purpose of these guidelines. If there was a need, what is the need? Do guidelines on the topic already exist? Is this an update? Have other agencies published a similar guideline? And if so, was it deficient, or why was it deficient? So this starts on page 1 of your handout. So I want to, this is, anytime you see a red light, that means that there's something deficient about this particular example. The recommendations in this document are intended to prevent infectious disease X in the U.S. In developing these recommendations, an ad hoc working group of experts was convened. So what is missing here from this description of scope and purpose? Anybody? Just call it out. Yes?
Well, more specifically, the target audience.
Okay. The target audience, who it's for. Anything else? Yes, sir? CDC recommends. Could be more explicit. Anything else that's missing? Remember, we're talking about scope and purpose. We said target population, CDC recommends. Anything else that's missing? Why you're doing these guidelines? The reason for it, the rationale? Anything else? Oh, yes. Okay, so the intended purpose and what it's going to, what's the ultimate purpose of these guidelines down the road? Yes. Okay, and also we're missing the setting and the intended audience. All right, so page 1 of your handout is a description of overall needs and objectives. This example was published by the CDC Prevention and Control of Seasonal Influenza with Vaccines in 2013. Annual influenza vaccination is the primary means of preventing influenza and its complications. There are many types of influenza vaccines, and the naming conventions have evolved over time. Routine annual influenza vaccination for all persons aged 6 or more months who do not have contraindications has been recommended by the CDC and CDC's Advisory Committee on Immunization Practices since 2010. This report provides updated recommendations and guidance for vaccination providers regarding the use of influenza vaccines for the 2013-2014 season. So what does this tell you? What is good about this example? What does it tell you? Anybody? Just call it out. Who's it about? What's it targeting? What's the intended purpose? The history of the recommendations. This is an update. And the time frame. Anything else? Very specific about the target population, people who are 6 years or more with no contraindications. Okay. Good. Target population. This is number 2 of your handout. This is an example published by the CDC Guidance of Evaluating Healthcare Personnel for Hepatitis B Virus Protection. Explicit guidance is provided for persons working, training, or volunteering in healthcare settings who have documented hepatitis B vaccination years before hire or matriculation, when hepatitis B vaccination was received as part of routine infant or catch-up adolescent. Okay, what does this section do? Well, anybody? Does it clearly describe the target population? Okay. So in this case, it's persons working, training, volunteering in healthcare settings who have very specific about who it's intended for. The guideline is for. Who is the end recipient of the guideline? Okay? This is a continuation of the number 2, the settings where the guideline is supposed to be used, such as the clinical setting or community setting. This guidance applies but is not limited to healthcare providers in acute care hospitals, long-term care facilities, nursing homes, skilled nursing facilities, assisted living facilities, physicians' offices, dental offices, rehab centers, urgent care centers, ambulatory surgical centers, et cetera, and to persons who provide home health care and emergency medical services. Okay, so why do you think it's important to say all these places? Wouldn't it be sufficient to just say healthcare settings? What is the added value of listing all these places? Yes. Okay. Okay. So it's good to be specific because it helps say who the guideline is directed to, and not all clinical settings might need this, like a pediatric urgent care center. Or the findings might not apply to those centers. There's another reason why it's good to specify all these places. I haven't heard that. What do you think it is? Sandy?
Elderly people are kept in many different settings, so you have to, your target population is the elderly and who's providing the long-term care, so you have to be inclusive of all the types of settings in which the elderly could be present.
Okay, so to be inclusive of all the types of healthcare settings where elderly populations are. The other reason that I'm looking for is if I'm the intended user and I see dental offices up there, it's going to get my attention as a dentist, and it might not be if it wasn't specified. So it helps reach the people that you want to reach by naming them specifically, as it does here. Good. Okay. Item number 3 on page 3 of your handout is a description of the intended audience or user of the guideline. This is the people that you want them to follow. That's different than the target population. That's the end recipient of the guideline. So this was published by the CDC U.S. Selected Practice Recommendations for Contraceptive Use. These recommendations are meant to serve as a source of clinical guidance for healthcare providers. Healthcare providers should always consider the individual clinical circumstances of each person seeking family planning services. This report is not intended to be a substitute for professional medical advice for individual patients. Persons should seek advice from their healthcare providers when considering family planning options. So what stands out to you about this description? Yes.
Well, what I like about it is it's really clear who's not the intended audience.
Okay, it's clear about who's not the intended audience. Anything else that strikes you about who it's for? It's very specific about who is the intended audience, but what else does it say that is a caveat? Okay, well, the caveat is this report is not intended to be a substitute for professional medical advice for individual patients. So here you've got the very clear guideline, but then it's saying, but consider your professional judgment when you're using this guideline. So that's really gives more leeway to the user in how they apply this guideline in their practice. Okay, number 4 is questions for systematic review. This is on page 3 of your handout. It's the long table. It's some of the questions from the systematic review that was published by the ECRI Institute for solid organ transplantation and the probability of transmitting HIV, HBV, or HCV. It's a systematic review, and that's when you want to get right. You want to make sure that that evidence is done well, which is probably why they contracted it out to a professional group, because it's so sensitive. But what they did well with this is they listed the questions that they were searching. Major topic on the left, the probability of transmission of HIV and HBV through organ transplantation, but the specific research question are, what are the prevalence and incident rates of HIV, HBV, and HCV among potential organ donors, and what are the rates of transmission from donors affected with these conditions? Do the rates vary by the organ transplanted or when the donor was infected? So the questions are very transparent. And why do you think this is important? What help does this help you do by being very specific? Anybody? Yes, John?
It's going to help you somewhat narrow your search parameters a little bit, because there are going to be references or resources, outside the scope of these questions, which might be interesting, but which aren't going to have the information you're looking for.
Okay, very well said. Helps you focus the scope of your research, and that will save you time by doing that. Anything else? It helped, yes.
Well, the other thing is by stating your questions, it will make you address those questions that there are no evidence, so that you're obligated to address them at the end.
So it may help you identify those questions that don't have any evidence, and that may turn into a research recommendation for future research, which I think that they did identify. So good point. Yes?
Yes, on the checklist, you marked that it's not critical for clearance. Why is that?
It's not traditional practice to list all the research questions in a published guideline or in a systematic review. This is a systematic review. This was separate from the guideline. It's not typical. It's a good idea. It's a good idea to actually have the questions, but whether you publish them, we don't necessarily need to see them.
Yeah, we only had one guideline with this. Doing it because I think it's a very, very good idea for all the reasons that Diane mentioned, John mentioned. That's why it's very, very important, and very, very few people do it.
The other thing that this does, too, is it helps everybody stay on target, on focus, including your external panel of what it is you're looking for, so you don't tend to stray away from your objective. Yes, Sandy?
If I may add, this also helps you when it comes time to grading how the recommendation, the evidence is, if the evidence is good or bad. Having a clear question that you can then grade later on how strong the evidence is, it will help you on did we answer the question or not.
Right. It keeps your literature search focused, again, with your questions connected. Yes. Okay. And number 5 is a description of whether the guidelines and recommendations are new or how they add to or differ from existing guidance. This is an example from the CDC selected practice recommendations for contraceptive use in 2013. Although much of the guidance is the same as the WHO guidance, the recommendations are specific to the U.S. family planning practice. In addition, guidance on contraceptive methods not available in the U.S. have been removed, and 4 new topics for guidance have been added. the effectiveness of female sterilization, extended use of combined hormonal methods and bleeding problems, starting regular contraception after use of emergency contraception, and determining when contraception is no longer needed. Okay, so what strikes you that's good about this statement? Yes?
I like that it specifies the country. Certain contraceptive methods that are common here may not be prominent in other countries. And then it specifies 4 new areas. Maybe these contraceptive methods aren't available in other countries. So I like that it specifies that it's for the United States, because maybe our needs here may be different from the needs of other countries.
So clearly specifies the reasons why it's different from the WHO recommendations, and specifies what is different about it, not just that they are, but in what's in parentheses of the things that they're different, the topics that are different. Did you have your hand up? No, just scratching your head. Okay. All right. All right, reporting on participants and competing interests. This is all the items that are listed in this section are critical and need to be addressed. And this starts on page 4 of your handout. All right. The new recommendations were developed by a CDC working group in consultation with representatives from various agencies. Okay, so this is deficient. What's deficient about it? I'm sorry,
You'd have to say who they were.
Okay.
And state whether they had conflicts of interest or not.
Okay, so there's no names. So we need to say who they are, whether there's competing interest. Anything else? Yes.
Sounds like it could be a potential FACA violation if they came to a consensus agreement. That's the first thing I thought when I read it.
Well, it's very vague, in general. There's no specificity about the names of the groups or the organizations or affiliations with the groups. And so we do need to see the steering committee members, the names, credentials, and affiliations of the individuals who are responsible for overseeing the development process, and that includes authoring, reviewing, and approving the recommendations as listed here from the contraceptive use guidelines. And also a list of work group members. This is the full list is on page 5 of your handout. Again, it includes the names, the credentials, the affiliations of the people who either selected, reviewed, summarized, or reported or contributed to the evidence. And it's a good idea to have a statement about who did what. And see, you have work group members and work group contributors. So what's the difference? I mean, what did they do that was different? That might be good to have a statement that clearly says that. Item number 8 is an example of a federal advisory committee for immunization practices that developed and approved CDC prevention and control of seasonal influenza with vaccine guidelines. Full description is on page 6 of your handout. ACIP is chartered as a federal advisory committee to provide expert external advice and guidance to the director of CDC on use of vaccines and related agents. Recommendations are harmonized to the greatest extent possible with recommendations by the American Academy of Pediatrics, the American Academy of Family Physicians. ACIP recommendations adopted by the CDC become agency guidelines on the date published in MMWR. So please note that MASSA oversees guidelines for federal advisory committees. I think we made that point earlier, and they have their own requirements. But what is good about this statement that strikes you? Anybody? No comments? Well, yes.
It tells you when the recommendations become valid, or the date of when they...
Okay. It tells you exactly when the recommendations will be made public and valid. Yes. John, did you want to add something?
Yeah, it sort of puts it in the landscape of CDC, a particular advisory committee, how that relates to professional organizations, how it relates to MMWR, so you can sort of, you know, if you need more information than just this is a CDC recommendation, this tells you kind of where that recommendation fits in the ecosystem, if you will.
It shows you how CDC guidelines fit with other recommendations, other professional groups, and yes?
Yeah, I have actually a question on the previous slide about work group members and work group contributors. Are CDC people always described as work group contributors? The previous.
Well, CDC should be listed if they are a contributor.
But they wouldn't be listed as a member. They're something different.
Are they allowed to be listed as a work group member, or are they required to be a work group contributor only?
I'm not familiar with any.
It's just a specific thing to this recommendation. It's not something you have to.
It's not like a template to follow.
It's not a
okay.
mandate of any sort.
There's no mandate. Going back to this one, I kind of dovetailing what John was saying is, I think it's good that they named these organizations, the American Academy of Pediatrics, the American Academy of Family Physicians. Those are your stakeholders. And the word harmony, it harmonizes their recommendations with these other groups. The fact that they said that, chances are there's going to be less pushback from outside groups by not saying it, if they didn't say it. Yes, Sandy?
In this type of recommendations with ACIP, having the blessing of the other organizations is very important, because sometimes the differences are just one word, but the interpretation by the physician, the practitioner that is administering the vaccines is dramatic in the difference between one. And there is a book that they go by, and everything has to be in agreement with that book as well.
So getting the blessing of other organizations is really important and really critical to preventing future problems down the road. Exactly. Okay. We've talked about what a disclosure of competing interests. Here's an example that was written from the CDC guidance for evaluating healthcare personnel for hepatitis B virus protection. The developers of these guidelines wish to disclose that they have no financial interests or other competing interests with the manufacturers of commercial products or suppliers of commercial services related to vaccines, including any related to hepatitis B vaccines, with the following exceptions. Now, if there was no competing interest, you could stop right there on that, where that comma is. I'm sorry, I have to use it over here on this screen, right there. But if there are competing interests, then you say with the following exceptions. Dr. WD wishes to disclose that he served as a consultant and on a speakers bureau, whether paid or unpaid, for the following vaccine manufacturers, Merck, Sanofi, and Pfizer. Dr. ABM also wishes to disclose that she received grant funding from the following pharmaceutical companies, MedImmune, Sanofi, and Merck. So this slide points out the importance of transparency to preempt any concerns that might be raised later about certain members. And it's okay to have these competing interests. They just need to be disclosed, and they need to be discussed in the manuscript of how they were addressed in the methods section of your manuscript. Now, I just want to point out that the MMWR has a requirement called, they call it disclosure of relationships. And that is a statement that begins in the MMWR documents that is for continuing education purposes, but it just applies to authors, and it only addresses financial conflict of interest. So that statement that you see in the beginning of MMWR is called disclosure relationship is different than what we are asking for, which will be placed at the end of the document near where all these contributors are noted. And it's called, ours will be called disclosure of competing interests, and it will cover not just financial interests, but it will cover any other type of competing interests. Does that make sense? Yeah. Vilma wanted to add a point.
Yes, I just want to note that you can see that it's adapted from those guidelines because we changed 2 words. They had, in the second line, they had have no financial interest or other relationships, and we put competing interests. The reason why we changed that is because of what just Diane said, that the MMWR has another requirement of disclosure of relationships, and we don't want to mix one with the other.
Yes, Chris.
Chris from OPHPR. So if the people that were the exceptions were actually CDC people who had done an honorarium and done the talking, they wouldn't have to put this? Is that true? No, let's say the 2 examples were not external MDs, but they were CDC employees, but they had the same competing interest. They wouldn't have to disclose it? Is that true? Well, but no, you could have a CDC employee go and give a general talk about something to these groups.
They need to disclose it.
They would need to.
Yes.
Okay, I wasn't sure when there was earlier in the meeting there was a discussion about some of this being covered, and it wasn't. It was talking about external versus internal, and I didn't understand the distinction.
I think what we were saying is with the OGE 450, which is designed for federal employees, we need to complete that, but that only covers financial conflict of interest.
Okay.
This goes beyond that. This covers more than just that.
So this would be for everybody, internal and external. Okay.
Yeah.
Thank you.
Yes.
Hi, I'm Hallie from the Division of Reproductive Health.
Hey, Hallie.
Is this where, in the previous presentation, you mentioned that it should a description of how conflicts or competing interests were handled? Mm-hmm. So whether people sat out of discussions, yes. Is this where that should be spelled out? Or?
No, this is the statement that goes. It should be very pithy and clear, like this, just like this at the end of the statement. But in the methods is where you would describe how the group handled competing interests. Were they excused from voting? Were they, did they eliminate their competing interest, or were they excused from part of the meeting discussion where the consensus was being done? That's where you go into the details about how you handle the competing interests. This is just the statement. We don't want any more than, this is pretty long actually, but this is just the statement, but how it was handled goes in the methods. Is that clear? Okay. All right. So now we're going into the methods. This is a description used to obtain and summarize the evidence, which we talked about. Now what should be in your manuscript starts on page 7 of your handout. This is where we see many of our gaps. And, you know, they just don't report methods. They may have done them, but they aren't always reported in the manuscript. I like this cartoon. Look, half the work is done. All you need to do is fill in the top part so we can legally say the bottom part. The bottom part is eating chocolate will make you look younger and thinner. Yeah. That's exactly right. But we've actually seen some guidelines that are very well done, very well crafted, but where's the methods that go along with them, you know? Where's the connection? So so that you really have to have them both there. This is not a critical item on your checklist, but we like to see logic models, which is on page 7 of your handout. They provide a top-level depiction of the flow of inputs or processes or interventions, such as a vaccine, that are intended to produce a desired outcome. The beauty of logic models is that they're a snapshot of the link between the recommendation or a group of recommendations and your intended outcome. So this one is from the community guide. So is a community guide. Yes. Thank you. There we go. So on the left side, you've got all the things, the inputs preschool child cognitive and intellectual performance, childhood development programs and family support will increase child's motivation, improve their social skills, improve their health, increase their use of preventive health screenings, and just basically support the child in all of these areas, which will in turn result in early identification of problems, which will increase the child's readiness to learn, and ultimately improve educational attainment and decrease social and health risks such as delinquency, drug, and alcohol use. So here you've got a picture is worth 1,000 words, and logic models help the reader understand quickly the intention of your guideline. So this is helpful to the reader, it's helpful to the intended user, and hopefully it will help with the adoption of your guidelines. All right, let's read this one. A search of the literature was conducted. Information used in the recommendations were derived from 5 studies and expert opinion. So what's missing? I'm sorry. All right, you guys say it one at a time. Go ahead. Or just keep calling it out. Either way. Everything? Yes, Hallie.
Information on which literature sources were used, whether it was done systematically, how data, or that data was abstracted, how many people worked on it.
Okay.
Would be a few things.
Databases, how the literature was done, the search was done, years included, search terms. Pat?
The way I explained it to people was I said, you want to include enough information that somebody could repeat your study. And so sometimes we have to put that in appendixes or like on a website because we give them all the search terms and everything so that they can actually repeat it. Because especially in 3 or 4 years, if you want to redo it, you want to know how to redo it to capture new literature.
There you go. Is it Pat, your name?
Oh, I'm sorry, Nancy.
Nancy, I'm sorry.
Yeah.
Somebody else was Pat up here. Nancy, so she brought a very good point up about have enough information in there, in your appendices or in your methods or both, so that it can be repeated, so the literature review can be repeated following the same parameters, so that when you do an update, at least you're in sync with what was done. So that's a good point. Just so many things that we see missing in literature reviews. And so you mentioned a lot of the things we are looking for. This is on page 8 of your handout from the Community Guide on the Effectiveness of Disease and Case Management for People with Diabetes. The scientific literature was searched through December 2000 by using the Medline database of the National Library of Medicine and other databases. The medical subject heading mesh terms searched were, and they provide that, text searches were performed on multiple additional terms. 22 dissertations were also excluded because the available abstracts contained insufficient information. Titles of articles and abstracts extracted from the search were reviewed for relevance, and our consultants provided additional relevant citations. So here they've got the mesh terms used, the databases used, lots of very specific information about how they went about searching. Here's a description of the criteria to select your studies. A lot of times we get questions about what does that really mean, search criteria. Well, search criteria can be the criteria used to search for your literature and you get your big body of literature, or it can also be the inclusion criteria that you use to condense the literature that you actually abstract. So it can be done on both ends. English language, you might want to limit it to peer-reviewed publications. Multiple publications of the same study are treated as a single study. The study has to include at least one pathogen. Studies must include data of at least 5 people or reported in 2000 or later. You might want to just look at studies that have control groups, or limit your studies by those that report outcomes 1 year post-intervention. So there's no rules for this except that be very clear about your inclusion criteria. Right. The table that's on page 8 and 9 of your handout, again, this is from the organ transplantation review, systematic review that was done, and they list all the criteria in that table. Methods to assess evidence quality, there's different methods that are in GRADE, the U.S. Preventive Services, the clinical guide and the community guide. It doesn't matter which of these methods you use or adapt, but please try to use one of them and adapt them according to your needs. And explain how you adapted the methods that you use to assess quality. Here, we use the GRADE evidence rating methodology, which has been developed for treatment comparisons and diagnostics. The GRADE system determines the quality of the evidence for a single outcome of a single comparison based on 9 factors. Quality here encompasses not only quality in terms of how well the study was designed, but also 8 additional factors, including inconsistency, indirectness, imprecision of the evidence, evidence base being all studies included for that outcome. Ultimately, the GRADE system yields an overall rating for each outcome, which ranges from very low to high. So it tells you specifically how they ranked the quality of the evidence. All right. Item 14, these are a description of the methods to obtain and assess expert opinion. Just saying we convened an ad hoc group and met and came to this recommendation is not enough. You need to describe what the group did and how they did it, how opinions were gathered and used. Did they use focus groups? Did they conduct interviews? Did they use a nominal group process? Did they vote? Did they consider the literature? This is from the contraceptive use guideline. CDC convened a meeting of 36 diverse experts. The evidence from the systematic review for each topic was presented, and participants discussed the evidence and translation into recommendations. They gathered input from the experts and finalized their recommendations in this report. It was peer-reviewed. Feedback was received from an external review panel composed of healthcare providers, and these providers were asked to provide comments on the accuracy, feasibility, and clarity of the recommendations. Areas of research that needed additional investigation were considered. Any comments about this? Does it seem like it's too much? No? It tells the reader what you actually did and how you got the expert opinion, not just that you got it. All right. Now we want to see on item 15 a narrative that describes the evidence for the proposed recommendation. Again, providing a table is not enough. Tables are good. Tables are where the evidence is. But the authors need to describe their tables in a narrative format. Synthesize it in plain English, plain language. For example, we had 5 RCTs that had statistically and clinical significant outcomes compared to 3 that did not. And then you cite the citations for those studies. So it pulls together in a very succinct way what is in your table. Andy, did you have a question, comment?
Just a quick point on that previous slide 14. That's a good example of the place that my earlier question addressed, this confusion between when you're asking a group to provide advice and recommendations on which they agree, and so that this de facto appears to be a federal advisory group, because CDC doesn't say we gathered input from the individual experts and then developed the recommendations. We just finalized the recommendations. So it sounds like they really came from that group.
Mm-hmm. It was not. Can you use the microphone? Vilma, can you use the microphone?
Well, I was just saying that it didn't come from EFACA, and I would suggest that you read the entire statement in the handout.
It looks to me like the feedback was received from an external review panel after everything was synthesized and the recommendation and pulled together. But I wasn't there. I don't know. I'd have to go back and read the entire document. It's not a FACA. Okay. Okay. Oh, you cleared it. Okay. Well, you would know then. Okay, so this is the narrative I mentioned. A systematic review identified 11 articles that examined various therapeutic treatments for heavy menstrual bleeding, prolonged menstrual bleeding, or both among women using IUDs. 9 studies. It summarizes the number of studies that examined the use of various oral NSAIDs for the treatment of heavy or prolonged menstrual bleeding among IUD users. And then it describes those studies, describes those findings. And this is from the 2013 contraceptive use. Okay, most guidelines indicate that somewhere there's a table, summary of the literature, although they aren't always reported in the guideline itself. That's okay, as long as it's either in the appendix or there's a website or a link that is in the guideline that people can be referred to where that information is located. That's all that we ask. This is in your handout on it's item number 16, page 13, and this is just adapted. This is not the full table, obviously, but what's nice about it is it has all the different categories for each study. We don't have a prescriptive, tables don't all have to look the same. We don't have a prescribed method for tables, but we do, it's always better to include as much information in your tables that you think you're going to need to synthesize your literature. All right, methods used to obtain and analyze economic data. I know there was a question earlier about this. This is not a critical element, since not all guidelines conduct economic analyses, but if there is a statement about a recommendation being cost-effective or cost-beneficial, we need to see how that was calculated. And we've seen that. We've seen statements like that without any evidence for how that economic analysis was done. This was adapted from the CDC guidance for evaluating healthcare personnel for hepatitis B virus protection. To examine the cost effectiveness of various strategies for assessing HCP protection from hepatitis B, 2 economic models that yield calculations of the incremental cost per quality adjusted life year saved were developed. And they go on to describe in detail the analysis, how the analysis was done. And of course, if you're going to report the economic analysis, you need to report the recommendations. The values need to be included. This is from the same guideline. For pre-exposure anti-hepatitis B testing followed by revaccination retesting if necessary, compared with doing nothing, the incremental cost per quality saved was over $4 billion for trainees and over $3 billion for non-trainees at 1 year, and it decreased to over $800 million and over $700 million respectively over 10 years. Sorry. Stand corrected. Over 800,000 and over 700,000 respectively over 10 years. So everything except for the logic model and the economic items in this section are critical, unless, of course, there's economic statements about economic efficiency, and if that's the case, then we do need to see the methods and the outcome data for the economics. That has to be reported. Okay, so now you've just done all the synthesis of the literature, and you probably at this point go, okay, we're not done yet. We still have to now develop the recommendations. So this starts on page 16 of your handout. All right, here's a cartoon that says, the question is, shall we follow the 5-year, $20 million, 500-page task force recommendations or just wing it as we go along? So the moral of this is to keep your guidelines succinct as possible so people will read them, and if they don't read them, they won't use them. If they don't use them, you won't have accomplished your goal. So you can keep it pithy. Just always think about, is there a way to say this with fewer words? As Thomas Jefferson says, the most valuable of all talents is that of never using 2 words when one will do. And that goes along with our plain language current policy. So item number 19, this critical element is to report the recommendations in an easy-to-read format, including your page number or your references of where the evidence is found in the document, such as a text box. We'd like to see the linkage between the evidence and the recommendation close together. So you've got the recommendation right here with the evidence summary following it. And sometimes we've seen those in text boxes, and it just makes our life easier when we go to clear things. Notice that that's an I'll read the recommendation. This is from the Contraceptive Use Guidelines. Amenorrhea does not require any medical treatment. Provide reassurance. If a woman's regular bleeding pattern changes abruptly to amenorrhea, consider ruling out pregnancy if clinically indicated. So this is a perfect if-then examples of a if-then statement, and Dr. Schiffman will be covering that in depth tomorrow using BridgeWiz software. And in the evidence summary, during contraceptive counseling and before insertion of the implant, information about common side effects such as spotting or light bleeding and amenorrhea, especially during the first year of use, should be discussed. A pooled analysis of data from 11 clinical trials indicate that a significant proportion of implant users had relatively little bleeding. So you succinctly summarize your data, your evidence, next to your recommendation.
I have a question.
Yes.
If your recommendation is long, like the influenza one was 60 pages, shouldn't this box be near the front because it's what people really want, and then the detail is there afterwards?
That's fine. Yeah, you can put it at the front.
Okay.
Yep. I think sometimes if you have a really long guideline, an executive summary is in order because, again, you want people to read it. So put it in the front and just provide the details in the back end of the document. Okay. Did somebody else have a comment? Okay. So another critical element is to describe the methods used to formulate the recommendations, again, where they form through consensus, majority vote. Did you use some of the new tools that we'll be sharing with you tomorrow, such as BridgeWiz? During October 4th through the 7th, CDC convened a meeting in Atlanta of 36 experts who were invited to assist in guideline development and provide their perspective on the scientific evidence presented in the discussions on potential recommendations. During the meeting, the evidence from the systematic review for each topic was presented, and participants discussed the evidence and the translation of the scientific evidence into recommendations that would meet the needs of U.S. healthcare providers. In particular, participants discussed whether and how the U.S. context might be different from the global context. So, Andy, I think that this kind of gets at what you were bringing up, the last couple of points you made about just how did they use those experts and just when did they bring in those experts and what did they do? Was it the beginning, middle, or end of the whole process? So I think that gets to what you were kind of bringing up. Is that correct, Andy?
Yeah, that speaks to it a good deal. It's just that the devil's in the details, and it just, one day you'll send something like this in, and it will fly, and the next day someone will stop it and say, wait a minute, this sounds like a federal advisory committee, and so we'd like to know just what to do so to be on the right side of that fence, and it's often difficult.
It's a tightrope, a balancing act, yes.
This is Cheryl from Birth Effects. I'll just clarify that I think in this particular situation, which I know somewhat about, I wasn't involved in it, but the fact that the experts were just brought in for this one situation and it's not a standing committee, that's what separates this from being a FACA. And if you contact the MASO people, the committee management folks, they send you basically a list of 6 or 7 questions for you to answer to determine if whether you're thinking about for a committee would fall under FACA or not. And this is one of those important distinctions.
Okay. Cheryl said that that they worked with a FACA committee on this one, or not? You did not. I'm sorry, I couldn't hear you.
No, I didn't work on this. I just happened to know about it.
Oh, okay.
This is Andy again. I guess one of the things I'm hearing perhaps is that when we are about to do something like this, it would be good to talk with MASO or somebody like that, whoever's the responsible party in this case, to clarify what we can and can't ask these folks to do so that we can get the right language and have it cleared up front. Is that?
Well, if it's a FACA committee, yes. But
well,
the point is that it's not a FACA committee,
no.
And we are trying to avoid being charged with having created a de facto FACA committee without authorization, because we don't have authorization to do that, as you said. CDC is not authorizing these. HHS is not authorizing these. Now there are too many.
In Birth Effects, we've talked about this a lot, and basically we had to counsel not only committee management, but OGC as well, our OGC representative from our center, to sort out those details.
Yeah,
So you had
Joanne, did you want to speak to that about, she mentioned the OGC representative.
Yeah, I know. Now the lawyers are involved. Yeah, it's getting simple, right?
It's back to my original point that it's not an easy thing to navigate these regulations, and we can hear that it does take some extra work. So yes, consulting with MASO is a good idea. Talking with us, we might be able to help point you to, but it's true, it's not easy, and that's why I also don't want to try to comment on the regulations here, because I'll stumble in there too.
No, I think the most helpful thing that I'm hearing is the consultation availability.
Consultation is available. We're here to help you navigate through these challenges, and MASO, please talk to them too. They're another wisdom that comes with many counselors. All right? Okay. So item 21 is a critical element that describes how the benefits and harms influence the recommendations. This is an example from the Community Guide on Interventions to Reduce Tobacco Use and Exposure to Environmental Tobacco Smoke. Potential benefits of education to reduce ETS exposure in the home include changes in tobacco use behaviors such as an increase in cessation attempts and successful cessation. No harms of community education to reduce ETS exposure in the home were identified in literature or by the chapter development team. So clearly they described the benefits and the harms. We actually reviewed a manuscript that said the benefits of a particular vaccine outweighed the risks, but they weren't specified in the manuscript, and so that went back to the authors to clearly state those things. Item 22 are the factors that influence the ranking of the strength of the recommendations. This example is from the Guideline for Reducing HIV, Hepatitis B virus, and Hepatitis C virus. And this is the organ transplantation guideline. Full description is on page 18 of your handout. Although it's not a critical element, it does give the recommendation more weight when it is addressed. It reads, we used a modified grade approach for evaluating quality of evidence and determining strength of recommendations. If weighing the critical outcomes for a key question resulted in a net benefit or net harm, then a Category 1 recommendation was formulated to recommend strongly for or against the given intervention, respectively. If weighing the critical outcomes for a key question resulted in a trade-off between benefits and harms, then a Category 2 recommendation was formulated. Recommendations were also assigned a level rating A through D to reflect the quality of the evidence base underlying the recommendations. So when the supporting evidence is weak, Use the best evidence you have, such as expert opinion or the gray literature. Again, going back to the anthrax case, they had to rely on animal studies because human studies weren't available, so obviously they used the best evidence they had to rank their recommendations. But when you do have strong evidence, it's good to show how you ranked the recommendations. Other considerations that inform the recommendations. This is a description of any issues like applicability. This is from the Community Guide on Tobacco Use Exposure. The same body of evidence used to assess effectiveness was used to assess the applicability of smoking bans and restrictions to different settings and populations. Smoking bans and restrictions were evaluated in a variety of settings, including hospitals and medical centers, offices of healthcare providers, workplaces, universities. The evidence of effectiveness in these studies should extend to most indoor workers in the United States. So what stands out here on this particular statement?
Actually, I advise to read your handout because the applicability to the result of the studies is in your handout. It's not there. The part that says the studies on representative samples of employed people in California and Missouri demonstrated that smoking bans and restrictions reduce self-reported exposure to ETS in workplaces community-wide. That was the result of the study.
So the guideline shows applicability across different states as well as different settings. And they say it. So, and then the other things to address are barriers such as ease of implementation, cost, capacity, training. On page 19, there's a full description of this example. A major barrier to efforts by local governments to adopt smoking bans is preemption, which is the passage or presence of state law with weaker smoking restrictions that prevents implementation and enforcement of stronger local laws. So why do you think it's important to address some of these considerations, these barriers and issues like that? Any value to doing this, John?
I mean, I know from the influenza world, sometimes there's a difference between guidelines, say from ACIP, and those coming from Cochrane or other places, and often it reflects the fact that CDC is trying whenever possible to make its guidelines more practical and not simply this is exactly the very narrowest interpretation we can come up with from the evidence. Because again, if you want your guidelines to be used, then actually the question is broader than just exactly what and to only what populations do these recommendations apply.
So John brought up a really good point about how to, if you want these guidelines to be used, you've got to talk about issues like applicability and address some of the barriers. What are the barriers and how can they be overcome so that they are used? And Nancy?
It also may help you when you identify these. For instance, a state could then change their law. That would take a while, but at least it would give them some direction to do that. And then also when you are evaluating the guideline, you might be able to produce some things that would help people overcome the barriers. So in laboratory medicine, if we have a barrier, it's practical implementation of the guidelines, so things like posters, checklists, educational things for physicians, something that the clinical laboratories wouldn't have time to do. If you can produce that for them and hand it out, it helps them implement the guidelines.
Great point. So Nancy mentioned that it helps not only to identify the barriers, but it helps determine ways that the guideline can be adapted and translated into different, more usable tools for the audience to use, and for other states, in this case, other states, to how they can kind of avoid the barriers in their state. So lots of good practical reasons for identifying this in your guideline. We're almost there. Okay, describing future research needs. The methods, what were the methods used to craft these recommendations? And any evidence gaps in which future research would be beneficial to informing further recommendations. Sometimes when you identify your research questions and you see there's no evidence for it, then that could be turned into a research need. In this case, from the organ transplantation guideline, the systematic review for this guideline reveals numerous gaps in the evidence that affected the guideline's ability to adequately address many of the key questions reviewed. The following are 20 specific areas recommended for future study. And this, the full list of questions for future study is on page 20 of your handout. This is not a critical element, but it is a place to capture some of the areas of interest among your key stakeholders and other interested groups, so you can address public comments as well as stakeholder comments. I just thought this was funny. Well, I guess we're the control group. Some of you may be feeling like the mice on the right side. Guidelines. So I just thought it was funny anyway. So basically, then we're almost done. This whole section on reviewing and vetting your guidelines, we talked about this a little bit early in the development process. You need to describe any comments that came through your vetting process and how those, in a succinct way, and how those informed your recommendations. So this is a critical element, and it describes the individuals, the organizations that reviewed and commented on your recommendations. This is from the organ transplantation guideline again. Authors shared the draft guideline with the expert panel and review committee and made revisions, posted it on the Federal Register for public comment. The Public Health Service Guideline Revision Working Group participated in the revision of the guideline recommendations in consideration of public comments and provided feedback on the full document. The draft guideline was shared with the expert panel and review committee for technical considerations. So why do you think this is important? Yes, sir.
No, I just had a question. This is Farouk Ahmed. Does this step occur after clearance or before CDC clearance?
Well, ideally before clearance. Yes. Yes, Vilma.
Yeah, when there is public comment or vetting of internal or external peer review, we clear the guidelines twice in the case that the comments, addressing the comments, modify the guidelines substantially. So we clear them twice, before it goes to public comment and after.
No, my question was if we can send it for public comments before CDC clearance, it will shorten our timeline. It will reduce the time.
Some public input processes, they have to go before clearance. But I will have to get back to you on which ones. I believe that the influential scientific information is before clearance, right?
Yeah. I mean, this is all part of the process of developing the guidelines, and so the process has to be completed before you have your final manuscript, and then that's the final clearance. Now, when something is going out to public comment, there's a sort of informal clearance where we look at them to be sure that there aren't going to be any missteps or challenges that you're going to face before you put them out to the public for the first time. So we work closely with the ADS and the authors to help that go as smoothly as possible. But all of your process needs to happen before the final clearance and approval. And you're quite right. If we did it another way, it would be shorter, but it wouldn't be as robust and end up with the best quality. And so you need to build in that time into the whole process for developing the guidelines. It is challenging.
Mm-hmm. And if you have very highly influential guidelines, it may be a requirement. You may need HHS to sign off on it. So it is a good idea to get your vetting process before you actually finish your guidelines. And this is kind of it's time consuming. We call it restructuring. We did that in 1998, 1997, and we used reorganization in 2000 and 2003. And what about strategic reorientation? We haven't used that since 2004. So this is, yes, the challenges that come with vetting and the back and forth and sometimes circular process that goes with getting people involved that have a vested interest. But these are the people that are going to spread the information about your guideline. You know, ultimately they're your friends, and they will get the word out if you do involve them, so that it's part of the process. And updating. Finally, this is a critical element. We need to see a description of when the guidelines and recommendations will be updated and the process for updating them. This is from organ transplantation. Future revisions to this guideline will be dictated by new research and technological advancements for preventing the transmission of HIV, HBV, and HCV through organ transplantation. So what stands out here on this one? What does it tell you? Yes.
They're telling you that whenever there's new information available, that they will update the guidelines to reflect that. So they're telling you, okay. They're not saying a specific time period, but whenever that information is made available, they will consider it and update the guidelines as appropriate.
Okay. So exactly. They tell you when there's enough information out there to require doing an update, that's when we'll do it. And also, if you have to leave early, if you could please complete your evaluation before you leave. Thank you. So there's no rule for the number of years that need to go by for updating. Okay, I just want to leave you with a few practical considerations related to scientific clearance. And this applies to other scientific documents that we review. However, there's some special considerations. We encourage authors to consult with us early in the development process. OADS is available. We are available for pre-clearance before it's actually gone through formal clearance. And this, we have found that this helps make the process go smoother. The earlier you see us, the better. We clear guidelines that are published in MMWRs, and sometimes we clear them as they're being edited by the MMWR folks. So sometimes there's an iterative process that goes on between us and MMWR. And we can see the guidelines before they go through the MMWR, so you don't have to wait if you want some input from us. We often get questions about who, and sometimes public health service guidelines need DHHS clearance, so that's something you have to figure into your timeline. These are some general rules for clearance. Anytime a CDC member is an author, there is CIO clearance. If there's no authorship from a CDC member, then it doesn't need to be cleared at CDC or certainly at our office. But again, we encourage you to discuss clearance requirements with your ADS in the early stages. And also consider cross-clearance and agency-wide clearance if your guidelines cut across other agencies and as well as other centers at CDC. So, Therefore, we're in complete compliance with all federal guidelines, and there's a chalkboard with all this gobbledygook. At this point, you might feel that all this looks like that, and that you're overwhelmed, but it's really not overwhelming if you just take it one step at a time. We hope that these elements and examples were helpful to you and straightforward. Certainly, I found your discussion and your input very helpful to us, and thank you for your time. And before you go, if you can please complete your evaluation for today and turn it in to Neelam. And then Neelam has some housekeeping comments before we end the day.
Thanks, everybody. Just really quickly, again, a reminder that we are not meeting here tomorrow, but instead at 8 a.m., bright and early. You'll find plenty of parking. 8 a.m. in the DLA. It's just a floor below this in the Distance Learning Auditorium at 8 a.m. tomorrow. Something else that was noted to me, another good resource is www.guidelines.gov. Guidelines.gov is a good resource. And lastly, for the remote audience, please send me your email with your full first and last name to the email address ositraining@cdc.gov. ositraining@cdc.gov. Any questions you have, if you need to receive the handouts again, anything, just email ositraining@cdc.gov. So remember, sign in tomorrow, send me, email your attendance. We need both days noted for you to get the credit. Thank you, everybody. See you tomorrow at 8 a.m. in the DLA.